Taping it in my phone. I'm not sure how the quality will be, but at least we have it. And Hannah also is taping it. What I will do is I will send the two files for the two parts to Nate through Dropbox because this is the easiest. At the same time, I'll be contacting IT if they can put it on the Echo, but it may take some time communication. Yes.
Would it be easier just to put it on YouTube or?
I don't have time for that.
Okay.
It would be easy to do many things, but I am concentrating more on this stuff for you than putting it in. I'm not. I can play with it, but I'm not used to that.
Okay.
So you will have it, and if you have any volunteer, please communicate with Nate. At the same time, I don't know how fast communication with IT would be with me. May take a day, two, whatever. But I will ask them to put it in Echo. The other thing I want to tell you, not because you are so nice and you are here, believe me, the breast course especially, one of the courses maybe I really recommend that you attend. There are lots of interactions, get more interesting when you go to the fibrocystic and the malignancy. So thank you for coming, and I think you will learn more if you come in this. Next slide, and this slide, I got a call, actually it was a text from one of your colleagues in the US Emily. It was one word, Dr. Aziz, thank you. I will just stop here. Because you don't see the information here in many places. You are a patient, let me start this like that. You are the doctor, and patient come to you and say, I have a mass. You examine and you find this. And this lady say she's in her 30s, late 30s, and you have this. What do you think right away? This is one of your relatives. What do you think? You're concerned, right? And the concern is what?
Metastasis.
Cancer. And I hear Paul saying metastasis, and somebody say cancer. What a huge difference. You know the difference? The difference is cancer only. After 5 years, 9 out of 10 will be alive. But metastasis, after 5 years, maybe only depends what type of cancer. Maybe only 10 or 20 will be alive. So metastasis, high stage. Remember this. But you are concerned, right? So, in fact, a call will be even has a bigger point of this is here because the patient can come to use the mass here, which is the axilla. What's usually present in the axilla? Lymph node. So you think, oh, metastasis, okay? Not only this. So you come to Dr. Aziz because Dr. Aziz is a specialist in fine needle aspiration. So Dr. Aziz put a needle here, and he is very good. In few minutes, he's taking it, and he look, and I look at the slide, and I see breast tissue. So now you think it's a lymph node. Breast tissue and a lymph node means what? Metastasis. So if you are not aware of this entity, and believe me, you will learn a lot about this with the time. There is a side that any pathologists hate. I'm sure you don't know about it. It's called wrongdiagnosis.com. We hate this site. Anybody came across that before? Okay, but if you are a pathologist, you know it very well. So you put a needle and see breast tissue. And you know, tumor, very well differentiated, can look like reactive breast. So here we go. This is metastasis. And sometimes the primary inside the breast is very tricky. You can't find it or hard to find it. So I'm giving introduction to this story. The story is the disorders of development in the breast. If I say the breast is blank, anybody can fill out the blank for me? Okay, if I help you and say the breast is a modified 2 words. Anybody help me with 2 words? Okay, I will help you more. A breast is a modified blank gland.
Sweat.
Sweat. So Carl is clever, sweat. But sweat can be what and what?
Water.
Can be eccrine or apocrine. So here we are. So the breast is a modified apocrine gland, and this can be a straightforward question. Can be in histology first semester, but absolutely can be a question in 4th semester. So the apocrine glands, they are skin glands, they are mainly located in the axillary area and in the pubic area. This is mainly. So believe it or not, the breast developed from the apocrine glands along this line, we call it the milk line. It's a line extending from the pubis to the axilla. It happened under genetic control and many mechanisms I'm not interested in now, but you can hit Google if you're interested. The formation of the breast happened in this location. But because actually it's coming from the milk line, any abnormality can happen along this line. You can have extra nipple, you can have extra breast. And that was a thank you, Dr. Aziz, from your colleague in the USMLE. So you can have a picture like this, and you have no idea what it is. The whole, and I cannot give you a question, but I give you the concept. The concept is the breast, which is a modified epidermal gland, arise from the skin along the milk line. What is a milk line? It's a line extending from the pubis all the way to the axilla. So anywhere along this line, you can have normal or abnormal. What I mean by abnormal, if you have a breast here, this is a normal breast, right? But it can also have cancer, right? It is. So it's a nipple here. You can have Paget disease here because anything. It's still a breast tissue. It's benign now, but like normal breast, it can get malignancy. So this is extra breast or nipple. If you don't have these notes in your slide, you can write it if you want. Extra breast or nipple. This slide. This slide, you have inversion of the nipple. Inversion of the nipple, generally, in the breast is a bad sign. It's a worrisome sign. Inverted nipple. Why? Usually, it may mean that there is pathology underneath pulling the nipple, and you get concerned first before anything, before fibrosis, before inflammation, you get worried about cancer. So inversion of the nipple, you take it serious. It doesn't mean that you have inversion of the nipple, so this is cancer. No, but certain type of cancer, you see inversion of the nipple, or the extension of cancer can pull the nipple. So the nipple inversion is a bad sign. But there is congenital nipple inversion. And I cannot tell you how you can get questioned in this, but I can tell you the concept. So you can have inverted nipple, and one of the causes, not just inflammation, not just cancer, no congenital. And this is now the important thing, the ectopic breast tissue. That you see the milk line is here. So yes, we have the breast here, but as we had tissue here, we have tissue here without a nipple. So you have to be aware of this. So if you are a pathologist, and you put the needle or took a biopsy and you see breast tissue, don't rush into, oh, it's metastasis, oh, it's cancer. Say, oh, maybe it is ectopic breast tissue. And we have our way in pathology to get into details of this. It's beyond the scope of the course here. But in pathology, we can go further. But for you, I want you to be aware that having a breast tissue not in the normal location, it can be, it's rare, but it can be what's called the ectopic breast tissue, and you can imagine how different scenario you can get, how many questions you can make yourself dealing with this concept. A very important slide. Now, inflammatory breast disorders, and this is what we go through. We go through inflammation of the breast, we go through an entity you have problem with, I don't know why, I'll give you a diagram for this. It's metaplasia of the lactiferous ducts. We have something called duct ectasia, fat necrosis, granulomatous mastitis. I will not talk about granulomatous mastitis because I gave you a slide with the pancreas, and I told you this you can see in any organ. Remember, pancreas, fine needle aspiration, and we saw three things: giant cells, epithelioid cells, and inflammatory cells. And if we see those, we are talking about what? Granuloma. And the first immediate step next management is you do what? AFB or culture? The next immediate step, you do AFB or you do culture? You do AFB, because AFB you can go to your pathology friend residence and do it right away in a few hours. But culture will take what? Take time. If the AFB is negative, that's it? Finished? No. AFB will be positive or negative. If it's positive, thank you. It's negative, no, we have to wait for the culture. Got that? Because this can be scenario in a question. You understand? So I'll not talk about it here because it's the same scenario. You do fine needle aspiration, you do biopsy, you do whatever. You have the exam description of a granuloma, or you see a picture of granuloma with the three things: epithelioid, giant cells, and inflammatory cells. This could be TB. We want to isolate the patient. Let's diagnose as Fast as we can, let's do FB so we can isolate. So please pay attention. Inflammatory breast disease, the patient will come to you with pain in the breast. You can have a mass and you can have nipple discharge. This is the symptoms that can be any one of those. We'll take the first one, acute mastitis. Acute mastitis, it's usually during nursing, commonly seen in the first few weeks of nursing. Of course, the breast will be swollen, and if it is getting bad, you can have abscess, and the abscess in the breast, it will be throbbing pain. Why throbbing pain? Because you have too much pus extending around and can't go out. And this is if you get a needle and just touch it, the pus will be out. That's why you have this fluctuant swelling. And if it happened that for some reason for a concern and you take a biopsy, all you see abscess, how it will look like that. So here is the breast, and usually it is early during nursing in the first few weeks. And you look here, the red area here and tense. And if get advanced, you see here starting to be more and more and forming an abscess here. What happens usually is just you whether make a tiny incision or even with the needle, and you just relieve the pus, and believe it or not, it gets healed with some antibiotic. But if it happens that you get concerned and take a biopsy, this is what you see. So this is the duct. The duct here more than one layer, so benign, and we have the intralobular stroma. And what is this? Anybody tell me what you see here? What do you think of this? You see, one of the nuclei, it seems like it is three. It's like that. If you look here, see, and you have lots of pink stuff called junk, and we have macrophages. So we are looking at neutrophils, we look at macrophages, we are looking at junk. What junk? Dead tissue and dead secretion. So if you have big area of this, it's called what? Abscess. So we have acute inflammatory exudates, acute inflammatory cells. The important, this is for you to understand the entity. If you see the picture of a patient come to you looking like this, but if you talk about question, here is the exam. They like to ask you what the most common organism. The most common organism is, yes, staph. It can happen with other. But if you see staph in the choices, this is the most common, and it makes sense because staph usually the infection in what? Skin. Okay? So please pay attention to this. Now this is the one that you have problem most time. Let's break it down. This entity is called squamous metaplasia. Let's stop here. Which means that it's arising from something that not originally squamous. Seems like there's something not squamous that became metaplastic into squamous. Then something happened. So the lactiferous ducts are coming from the alveoli and the ducts, and they are lined up by what kind of epithelium, the duct and the alveoli? Squamous or columnar? Columnar gland. Okay, so it seems like this entity, seems like some of this lactiferous ducts, you have squamous metaplasia in it, and because of this squamous metaplasia, some complication will happen. So let's see it now. Before I see it, I'm showing you the normal. So here is a normal. This is like, say, this is a nipple here, and here is the rest of the breast. This is the right breast, so we can understand. So we're looking like that. So this is the skin, stratified squamous, right? And the pinky area is the areola, and here is the nipple, and here is the erector pili that causes erection of the nipple. So we know the area here. And the skin is outside, and once it starts to have the duct, it becomes here columnar, or remember I told you cuboidal. Think of cuboidal as a small columnar, because columnar gets shorter, we call it low columnar, then cuboidal. But cuboidal, think about it as gland. So here is the gland, the lining, and here is the normal squamous. So this is a normal before we see the abnormal. What happened, it seems like for lots of reasons, inflammation, irritation, whatever, there is metaplasia here in the cuboidals. This cuboidal becomes squamous. It will become squamous as metaplastic. When squamous produces too much, there is a substance usually produced from the squamous called what start with K. Keratin. When you have too much squamous here, and there's lots of movement in the nipple with the muscle, so you can have lots of keratin here. So the keratin here will do what here? See what this is an opening now. If it's all keratin now, what will happen here? Plucked. But we have secretion coming. The secretion will accumulate here. Any stasis in general is an invitation to what? Bacteria, to inflammation. Any stasis is invitation for bacteria. So you develop an abscess here. All of this, and this is blocked. Remember, abscess have throbbing pain because you have the pus want to get out. The pus tried to get out from here, but there is no way. You know what the pus will do at this point? Will penetrate through here and eventually open up in the skin. You have an abscess, and you have a pus, pressure, trying to get out, but it is blocked. And because it is blocked, the pus will now creep into the connective tissue and make a hole to get out, and this has a name, and the name starts with the F. F stands for what?
Fistula.
Fistula. And what is the best description of the word fistula?
Connection.
Connection, I heard the connection. Anybody from New York here? How about a tunnel? Think of fistula as a tunnel. So here you are, from Long Island to Manhattan, or from Manhattan to New Jersey. So a tunnel. Think about it. So now, this what I explained the normal, here it is now, in reality. So what happened here, this area here, I'm showing it here. So see, here is the keratin blood. And because of the metaplasia extended here. So abscess continue here. The abscess now, the pus trying to go here, cannot go here. So they will keep pressuring in the fibrofatty tissue to open the tunnel here. And this is fistula opening at the edge of the areola. And this is a purulent with inflammatory exudates, and the whole thing happened because of the squamous become metaplastic inside. And the reason for this metaplasia, as I said, can be inflammation, can be irritation, can be many other, whatever it is, it can cause this. This happened, and because it's silly, because I don't know, it's not that. So you can see this in question. So pay attention to this. This condition is more common statistically in smokers. You may ask why. It's again, if we cannot go in details in everywhere. If you get interested, just hit Google or email me separately. Okay, but this is more common in smokers, and this can be a question. Pay attention to this. So I think this entity is understood, right? You usually have problem with this. I don't know why, and I cannot tell you what kind of question you can have with this. But I'm sharing with you, teaching you the concept, what happened. And based on this, you can imagine yourself what kind of question you may have here. You cannot memorize question, but you can memorize concept. And here it is. Let's see what happened here. What's happened here is we want to open this plug, because we want to open this to have more drainage and allow this part to heal and give antibiotic, local and systemic, so you get treatment. So we put a probe here, and we keep pushing it in the keratin to open it, and this is what we did here. So this is actually the fistula, and the tunnel is in between. So actually the probe is here. We put it here, and we kept pushing this to get it open here, so we can now treat this and have the normal flow again. Something called the lactictasia. So we finished the acute mastitis, and before we finish the acute mastitis, I don't know there are mothers here, but let me ask you this here, right here. A mother comes to you, and we know that acute mastitis happen in the early feeding the baby in the first couple of weeks. So the mother comes to you with this, and she's telling you it's continuously oozing pus. What do you think the next question the mother will ask you?
Can I still feed the baby?
So Cole is saying the question, can I still feed the baby? I think it makes sense. The mother is concerned. Okay, who says feed the baby? Who says don't feed the baby? Who says feed the baby? who said don't feed the baby. Okay, if you see it in the exam, do you want me to tell you what you should? Or when you have the patient coming to you, do you want me to tell you what you should tell her?
Yeah.
You should tell her feed the baby. Okay? So she will tell you, oh, but there is bus. You may suck the bus. What you will tell her? This is medicine, guys. You know, she is with you, you know, and they're asking you.
Isn't that extremely painful though? I would say no because of the comfort of the mom.
Yeah, okay. So the explanation, this is very painful, and for the comfort of the mom, I'll tell her don't. Okay, it was my experience, I will tell you. The mom, when you are a mom, you would kill yourself to save your baby. And you wouldn't think of any pain. The question I'm telling you, the question will be, what is good for the baby? If it's a little pain, no, there's no problem. But if it's something dangerous for my health or the baby, at this time your life is this baby. Good point, yes, Mne?
Can we just tell her to use the other breast?
Yeah, okay. Yeah, I think
Focus on the other breast?
I love this because
The spread of
it's not spread. Yeah, Hannah saying spread, not spread. I love this because this is really the real medicine. And guys, we are learning all of this because you are becoming doctors. And not only we are learning this because of becoming doctors. No, believe me, this scenario or similar scenario, you see it in the exams. Because I keep telling you, you are seeing patients all the time. You don't see them physically, but you see them in the exam. You can have these scenarios, and exactly one of the choices can be like this. Of course, if the other breast is available, of course. But if they are both, okay, disappointing, man. But if they are both, then they say, oh, there is bus. So what we tell them, okay, before you feed, just squeeze it a little, clean it as much as you can. But what I want to tell you is that the pus will not hurt the baby. There are lots of colostrum from the milk and there are antibodies and stuff. The point here is feed the baby. Of course, you know, we're talking standard. If there's ugly, gangrenous things, you know, we're talking about the normal mastitis coming to you is not a reason not to feed the baby. Very important, please. So, another one, maybe we'll do one or two before the 10. So, we'll go through this. So, we'll do ductal ectasia. And again, those things are really popular in the exam. What is ductal ectasia? I will read it, then explain to you. This is one thing of ductal ectasia, elderly, not young. And it is inflammation, non-bacterial. It is not inflammation. You know that inflammation, even practicing physician, they think inflammation, infection. Right? Many people think of that. Inflammation, infection, polys. Yes, infection is one of the causes of inflammation. But inflammation, the one word for inflammation actually is injury or insult. You have a cut in this by knife here. Then you'll have healing. Healing will heal by what? By inflammation. So when we say non-bacterial colonic inflammations, or when I say inflammation without being infectious, and it is associated with white, thick discharge, this is my experience. And because people were jumping all over, no, we read this in Bathoma, so okay, I added that for Bathoma, okay? Because I used not to have the brown, and everybody, Bathoma is brown, so fine, brown. It's white,